our patient was 72 years female, and she was a known hypertensive. She had class 2 dyspnea for 1 year, and now for the last 1 month she had class 3 dyspnea, and was also having palpitation for the last 1 month. She came with claudication of the right calf for last 6 months, and for the last 1 week she had rest pain, and there was numbness and bluish slight discoloration for the last 1 day. On examination, her BP she was hypertensive, 180 by 110, heart rate was 160 per minute, and she was in atrial fibrillation. There was all pulses, including popliteal on the right side, below popliteal were not palpable. ECG shows atrial fibrillation, and echocardiography showed that there was a left ventricular hypertrophy with diastolic dysfunction, and she had left atrial appendage clot. This was our angio done from the contralateral side, and it showed that there was a total occlusion of the right popliteal artery. So we put a right guiding catheter, Jurgen's right guiding catheter, and made some holes in it and tried to pull the clot from the popliteal artery. This was the picture after extracting clots. But it again got occluded. Then we tried to push the wire, initially BMW wire. Then we took export catheter and tried to extract clots from this. There was some visible flow distally. Again, we tried with the guiding catheter, and then at least anterior tibial opened up. After that, we again took export catheter in the posterior tibial. And we found that there was a tight stenosis in the proximal part of the anterior posterior tibial. We dilated it with 3 into 15 mm balloon. There was again a tight stenosis. Then again we did another dilatation. So this was the final result. We could make at least 2 arteries patent to the lower limb, and the patient's symptoms improved. Her pain disappeared, and it is now around 6 months follow-up, and she is asymptomatic.
It was a good case. Did you give some lytic?
We gave intra-arterial streptokinase, and also 2V3 inhibitors.
It was just a bolus, or you continued with infusion for some time?
No, just bolus.
We have done similar case, but we puncture the femoral artery integrate with the 8 French C, and then 7 French guiding. We took used filter in some carotid, and put distally the filter, and then we shuck out with the side of the wire with another guide catheter, either right coronary or multipurpose, several times, and after that we keep some.
What was the cause of stenosis in this 27-year-old patient?
It's not 27, it was 72 years. It was atherosclerotic. It was 72 years.
Otherwise, this is a simple case of embolectomy.
I think it depends on the thrombus load also. Sometimes you have a very large thrombus, which
to surgical embolectomy is the treatment of choice.
Suck it out from a coronary.
In some cases, we can do by putting filter distally and then sucking with the side catheter.
I'll just put in a word of advice, like I'm a surgeon and an interventionalist both. Whenever you're doing these interventions, just be careful for distal embolization.
Yeah.
Because if you throw this clot, very common, it's not uncommon. So I'll advise that rather than doing the ballooning directly, so just put in the lytic first, so the clots come soft and all, and then do the, because as a perfusion. Because if you throw the clots in the distal vessels, we can't even do an embolectomy, because you see, even 80% of the vascular surgeons, they don't do posterior tibial artery and embolectomy. So only 10 to 15% of the vascular surgeons do posterior tibial artery embolectomy. So most of the surgeons in your hospital will not be able to take the clots out from the distal posterior tibial artery. So just be careful that, because once you block the vessels distal to the ankle and all, even if you have a very good pulse coming in, your half of the foot, can really go.
In our setup, they are not doing below knee. She had to lose her limb, so we did this.
It's okay, but otherwise the primary treatment choice is the embolectomy.
Yeah, Charles is embolectomy.
Yeah, Dr. Bhardwaj,
what dose of streptokinase and whether after bolus do you recommend infusion? If the embolus you can't, if you are not able to suck it out completely, some residual thrombus is there, then how much streptokinase and how long would you like to give?
Yeah, preferably if we are not able to suck out, then we are not using intraarterial thrombolysis after that. We are giving intravenous 2.5 lakh bolus in a half an hour, then 1 lakh per hour till we get revascularization, and at the most for 24 hours.
I think catheter-directed thrombolysis, catheter-directed thrombolysis is better because you already have access. And if you can give locally intraarterially, and I have used in 3 cases retiplase actually, we gave 2 to 3 units intraarterial bolus and followed it with 1 unit per hour infusion for 24 hours. And we saw some decent results. Because if the thrombus load is much, you can't suck it out completely, the distal flow will not be very good. So thrombolytic is a good idea. Bolus of 2 to 3 units of retiplase followed by, or acrylize, whatever you have in your shelf.
Yeah, at the table we gave 1 lakh intraarterial, but afterwards, if we are not successful, then we are shifting the patient to CCU.
No, you can leave an infusion catheter inside and give it.
At that point, we are giving on the table.
Thank you. I think we move.
I want to know from the panelists whether the consensus for acute limb ischemia presently is for embolectomy or this thrombolysis.
No, you see, it all depends upon what stage the patient is. You see, if the patient clinical foot is so ischemic that you think that the foot is not going to survive for 24 hours, then it's better to go for an embolectomy because you get an instant result, because it's not going to give you time. And some people in our own hospital, sometimes they go for this thrombolysis and doing an angioplasty, and the limb is acutely ischemic. Then, because there could be some delay when you do when you do a catheter-directed thrombolysis and all, then you could land up with mostly anterior compartment, the muscles they die, and then you land up with you have to do all this fasciotomies and all. If you think that your limb is acutely ischemic and it cannot sustain for another like 12 to 14 hours, and on an angiogram your load is quite a lot, then it's better to go for an embolectomy. And if you think the load is very localized and you can get away quickly with the thrombolysis or with an suction of the clots, then it's better to go for catheter-directed thrombolysis.
If it is very acute, it is you can thrombolyze. But if once it gets organized, the thrombolysis doesn't work usually. So more than 24 hours, it's always better to send the patient for.
We have a patient of graft occlusion due to thrombosis. Patient underwent FEMPOP. After that, the graft got occluded with a thrombus. So what do you recommend? Should we thrombolyze that graft with the intraarterial injection of thrombolytic therapy, or you recommend some surgical intervention?
It's a plastic graft, a PTFE or a DAC graft.
This is a composite graft from femoral to popliteal.
So you see, in any acute limb ischemia, the principle remains the same. If you have a graft, and if your foot condition is, you see, quite a lot of time we see that we have whatever graft we have done, once they get a clot, the patient either comes in severe limb ischemia, where you have to take the patient immediately into the surgery, or the patient can come with a mild rest pain, which can be controlled, but the foot perfusion is maintained, and there is no calf tenderness, and there is no, all the compartments are not tender. So that means the muscles can survive. So then you can try for thrombolysis. But if you think there is a calf tenderness, patient is in extreme pain, which is not getting controlled with simple painkillers, then it's better to take in for surgical thrombectomy.
Thank you.
It means that if the problem is very serious and severe, then the thromboembolectomy should be done, and otherwise, if in a subacute or mild case, the thrombolysis can be done.
Absolutely.
Pure thrombolytics works when there is some recanalization, means some flow antigrade.
Yeah.
Otherwise, it won't work. Whatever you give, it doesn't work. You have to do embolectomy. So thrombolytics work when there is some antigrade with the clot. If there is no antigrade flow, nothing going to work by medicine. You have to. Even then it won't work. No, you need some antigrade flow to have thrombolysis to work.
I think acute limb ischemia is a very common clinical scenario. We have generated enough discussion. We move on to the next case.
Thank you very much. We move on.